As I have previously mentioned, the small intestine and colon are very effective organs in water absorption. However, if the system is overwhelmed and the GI tract cannot absorb the water that reaches the intestines, then the result is diarrheal disease. Now, there are four main pathophysiologic mechanisms for diarrhea, and in general, in most cases, you will get a combination of these mechanisms. And these are first secretory diarrhea, osmotic type of diarrhea, the third is exudative diarrhea, and finally diarrhea secondary to deranged motility. And we are going to discuss each one of those mechanisms. In the secretory type of diarrhea, there is either active intestinal iron secretion or inhibition of normal iron absorption. Typically, this diarrhea persists during fasting and stool osmolality is normal, which means calculated stool osmolality minus 2 times sodium plus potassium is less than 40, and I will explain this. Usually, what is responsible for the osmolality of stools is the presence of sodium, potassium, and their anions. So if you measure in the lab stool sodium plus potassium and multiply by 2, you will get the approximate osmolality of stools. This is called calculated osmolality. Normally, the difference between the calculated and the measured osmolality is less than 40, and this is what we call osmotic gap. But if it is more than 40, then there is something other than sodium and potassium that is responsible for this increased osmolality. Then we will say that the patient has an osmotic type of diarrhea that we will discuss later on. Now, in secretory diarrhea, there is either decreased surface area available for absorption, or there is overproduction of intestinal secretagogues, which are substances that increase secretion from the enterocytes themselves or inhibit the normal absorption. The decreased surface area available for absorption can be due to several reasons, such as intestinal resection, like in Crohn's disease or intestinal ischemia, or diffuse mucosal disease. The diffuse mucosal disease includes conditions such as celiac disease, where there is destruction of the villi that are responsible for digestion and absorption. You can get this with lymphoma, where there is destruction of the enterocytes, or with chronic infections like Whipple's disease or tuberculosis. Even in acute infections, we get secretory diarrhea, for example, with enteroinvasive E. coli or rotavirus, leading to destruction of enterocytes and again decreased surface area available for absorption. The second mechanism for secretory diarrhea is the presence of intestinal secretagogues, which can be either toxins like cholera or E. coli toxins, can be secondary to bile salts, to fatty acids, or to the presence of some neurohumoral mediators like vasoactive intestinal polypeptide, 5-hydroxytryptamine, or gastrin, and we are going to discuss a few of those. One of the most studied toxins is cholera toxin, and cholera toxin is formed from 5 beta subunits and 1 alpha subunit. It binds to a receptor on the enterocyte, and then part of this alpha subunit crosses the cytoplasm and stimulates adenylate cyclase, which is the presence of the basolateral membrane of the enterocyte, leading to increase in cyclic AMP. This binding is an irreversible binding until the death of the cell, and normally the lifespan of the enterocyte is 5 to 7 days. This increase in cyclic AMP will lead to protein phosphorylation, causing opening of the chloride channels and subsequent chloride secretion from the enterocytes, and then water will follow chloride secretion. At the same time, there is some inhibition of the sodium hydrogen pump, leading to a decrease in neutral sodium chloride absorption. This is why in cholera the diarrhea will continue until the death of the cell, which is approximately 5 to 7 days. So when enterocytes die and new cells are formed, the patient recovers. Note that cholera toxin does not by itself cause cell death. This is a most important point. Patients with cholera may have torrential diarrhea with 7 to 9 liters of stools every day, but all what they need is hydration. The second important toxin is the heat-stable toxin that is produced by E. coli. The toxin binds to a receptor on the brush-border membrane called the STA receptor, leading to stimulation of guanylate cyclase with increased production of cyclic GMP. Similarly to cyclic AMP, cyclic GMP causes an increase in protein phosphorylation, leading to opening of chloride channels and inhibition of sodium chloride absorption. The effect of E. coli toxin is much less than the effect of cholera toxin. Diarrhea can also occur secondary to secretion of fluid from the colon, and one of the causes is the presence of bile acids. As I have already mentioned, bile acids are normally absorbed from the terminal ileum. So if the terminal ileum is diseased, like in Crohn's disease, or if the terminal ileum has been resected for some reason, or if there is malabsorption of bile salts from the terminal ileum, then bile will reach the colon and will stimulate secretion of water from the colon, hence the bile salt-induced diarrhea. In a manner similar to bile acids, if hydroxy fatty acids reach the colon, they also can cause diarrhea. Hydroxy fatty acids are produced from dietary lipids by enzymes of the enteric bacteria. So here again, if there is fat malabsorption, fat is not digested and it will reach the colon where it is fermented by bacteria with the production of hydroxy fatty acids. Hydroxy fatty acids are secretagogues in the colon, inducing secretion of water. Diarrhea with the presence of fat is called steatorrhea. One medication that is used as laxative is called castor oil or zataharwa. It is a hydroxyl fatty acid which can induce secretion of water from the colon and cause diarrhea. It is used sometimes to clean the colon before an X-ray or before some other procedures. Sometimes it is used as preparation for colonoscopy as well. There are some rare tumors that can secrete mediators that cause diarrhea. For example, carcinoid tumors secrete serotonin and prostaglandins, and serotonin is an important secretagogue. There are tumors that secrete VIP, which is vasoactive intestinal polypeptide, and these are called lipomas. And VIP as an important stimulator of cyclic AMP, which increases secretion from the intestine. Other tumors are gastrinomas, medullary carcinoma of the thyroid, ganglioneuromas, but I'm going to discuss a little bit how gastrinoma can cause diarrhea. In gastrinoma or Zollinger-Ellison syndrome, there is an increase in gastrin production. And gastrin production will increase HCl production from the stomach, so there is an increase in the amount of fluid secreted by the stomach, because increase in HCl is associated with increased fluid secretion. The increased acid reaches the duodenum and stimulates bicarbonate secretion from the pancreas and from the liver, and thus there is increased fluid secretion into the duodenum. But the most important effect is that the amount of acid in the duodenum is much higher than normal, and the secreted bicarbonate from the pancreas and liver are not enough to neutralize all the acid that goes into the duodenum. So there is an acidic medium in the duodenum, leading to inactivation of pancreatic enzymes, resulting in maldigestion of fat. So fat will reach the colon, leading to steatorrhea and diarrhea. Now we move to the second important pathophysiologic mechanism of diarrhea, which is the osmotic type of diarrhea, resulting from an accumulation of non-absorbable water-soluble substances in the intestine. Typically, the osmotic diarrhea stops upon fasting because once the ingestion of the non-absorbable substance is stopped, the diarrhea will stop. And typically, the stool osmolality in this diarrhea is high. So if you calculate the osmotic gap, it will be more than 40. So stool osmolality minus 2 times sodium plus potassium will be more than 40, indicating the presence of some other substances in sodium and potassium that increases the osmolality of stools. There are several causes of osmotic diarrhea. First is dumping syndrome, then the presence of osmotic substances, and lactate deficiency. In the first reason, which is the rapid emptying of hypertonic foods from the stomach, it's called dumping syndrome. And as you know, the stomach acts as a storage site in the process of digestion. So in patients who have had a bypass surgery and a part of the stomach has been removed, the contents which used to be stored there and delivered slowly to the intestine are being dumped faster than the ability of the intestines to handle, especially that the pylorus, which regulates the rate at which chyme goes from the stomach into the duodenum, is also removed during these surgeries. So now there is a hyperosmolar medium, the small intestine, and water will move from the tissues into the intestine by osmosis, causing an osmotic diarrhea. Dumping syndrome is usually associated with hypotension, presenting as postprandial dizziness, because of the quick shift of fluid from the systemic circulation into the intestinal lumen, as well as sweating and hypoglycemia, secondary to very quick rise in insulin. The second cause for osmotic diarrhea is the presence of osmotic substances like magnesium salts, polyethylene glycol, and lactulose. These substances are not absorbed from the small intestine and therefore exert as an osmotic force and draw fluid from the circulation into the intestine. And last cause for osmotic diarrhea is lactate deficiency. So when lactose is not absorbed in the small intestine and it's not digested, it builds up and also causes an osmotic shift of fluids into the intestines. The third broad type of diarrhea is the exudative type. And exudative diarrhea results from extensive injury of the small bowel or colon mucosa as a result of inflammation, infection, or ulceration, leading to disruption in intestinal permeability and loss of mucus, serum proteins, and blood into the bowel lumen. Inflammatory cells may also secrete immune substances and cytokines, which may affect permeability, stimulates intestinal secretions, activates enteric nerves, and may affect carriers and transporters, thus increasing secretion and motility of the intestine. Increased fecal water and electrolytes excretion results from impaired water and electrolyte absorption by the inflamed intestine and from secretion of water and electrolytes into the excrets. The fourth major pathophysiologic mechanism of diarrhea is deranged motility, and this type of derangement can cause diarrhea whether there is enhanced motility or decreased motility in the intestine. Now, for the enhanced motility, usually the intestine has to take their time in absorption of digested products and also to absorb fluids. If the water passes very quickly into and through the small intestine, there will not be enough time for it to be absorbed. This will result in decreased absorption. Examples of such derangements are carcinoid syndrome, diabetic neuropathy, irritable bowel syndrome, and hyperthyroidism. Also, in acute infectious diarrhea, there is an increased motility of the intestine and colon, in addition to what we have already mentioned about the injury to cells or to the presence of some toxins. Now, in decreased motility can lead also to diarrhea, and this is secondary to the stagnation-induced overgrowth of bacteria, especially in the small intestine. The overgrowth of bacteria in the small intestine will cause an increase in deconjugation of bile salts, and thus bile salts are not available anymore for digestion of fat, and this leads to steatorrhea. One example of this is scleroderma, where you have decreased motility of the intestine leading to bacterial overgrowth and steatorrhea. Now, clinically, there are two definitions of diarrhea, one as a symptom and the other as a sign. As a symptom, it is a subjective definition in which the patient presents and reports diarrhea. In reality, this could mean increased frequency or subjective increase in volume of stools or a change in consistency. So this is a subjective definition by the patient described what I have. However, as a sign, for a more objective definition of diarrhea, if the weight of stool is more than 150 to 200 grams per 24 hours, then the patient is said to have diarrhea. In general, in practice, we rely more on symptoms rather than on the signs for defining diarrhea. Diarrheal disease is very prevalent, with approximately 3 to 5 billion episodes per year. It occurs more in developing and underdeveloped countries. There are 5 million deaths per year from diarrhea. 80% occur under the age of 1 year, and this is mostly in developing countries. It is a major cause of work absenteeism and has a major economic burden, particularly in developing nations. Clinically, the physician should differentiate between two types of diarrhea, acute and chronic. An acute diarrhea is a diarrhea that lasts less than 2 to 3 weeks. The most usual cause of this type of diarrhea is infectious, and in general it is self-limited. It usually resolves without antibiotics. Chronic diarrhea has a duration of more than 3 weeks. It requires investigations, and there are multiple etiologies. The course may be variable. The diarrhea may improve for a while, or may get worse, or it may stop and come again. The major causes of acute diarrhea include the following conditions. 1. Infections, which can be bacterial, parasitic, viral, or fungal. 2. Food poisoning. Sometimes it's not the organism itself, but the ingestion of preformed toxins by the organisms shed in the contaminated food that cause diarrhea. This is also self-limited. 3. Medications. Many medications can cause diarrhea, so always we have to read the pamphlet of the medication to see whether one of the side effects of the newly started drugs is diarrhea. 4. Ingestion of large amounts of poorly absorbable sugars, like sorbitol, which is an example of such sugars. It's not absorbed and this causes an osmotic type of diarrhea. 5. Acute intestinal ischemia, especially in the elderly, who may present acutely with diarrhea. Pelvic inflammation, which may cause diarrhea just by irritation of the rectum. The patient more commonly may have frequency rather than diarrhea. And finally, fecal impaction. This is a paradoxical type of diarrhea. When there are hard stools in the rectum, all that passes is fluid around the impacted stools. Thus, the patient will go to the toilet many times with passage of small amount of liquid stools. This is called diarrhea secondary to fecal impaction. These are examples of some pathogens that can cause acute diarrhea. As you can see, pathogens can affect small bowel or large bowel, leading to diarrhea. I'm not going to go over the different types of pathogens, as these will be covered later on by Dr. Bistri. When you encounter a patient with diarrhea, you need to inquire about the following aspects of the diarrhea: the volume, diarrhea and frequency, the presence of blood or mucus in stools, and this differentiate invasive or non-invasive sort of bacteria or pathogens, the presence of fever, the severity of abdominal pain. You have to ask about travel history. Traveler's diarrhea, which occurs in travelers, may be secondary to infections with Giardia, E. coli toxin, or amoebiasis. You have to ask about any drug intake, like antibiotics, which can cause pseudomembranous colitis due to Clostridium difficile toxin. You have to ask about any new drugs intake because, as I've said, many drugs can cause diarrhea as side effects. You have to ask about any recent or what recent food consumption the patient had, like for example raw seafood or shellfish or raw meat. This is an important cause of diarrhea, and the physician needs to know whether the patient ate at a restaurant or if other people who had the same food developed the same symptoms. With the first encounter of a patient with diarrhea, what we are really interested in is the severity of illness rather than the cause of the diarrhea. So always keep in mind that when the patient is losing fluids from diarrhea, if not replenished carefully, he might get dehydrated, especially in the elderly. So check if the patient is dehydrated or not. This is done through inspection of the mucous membranes, whether they are dry or moist. The patient's blood pressure should be measured sitting and standing, looking for any possible orthostatic hypotension. Capillary refill test could also be done to assess hydration status. Next, on abdominal exam, one should check for distension, if the abdomen is quiet or that the patient has a tender abdomen. Look for hypoactive or hyperactive bowel sounds, and a digital rectal exam should be done. This information will help us look for or determine whether the patient needs further testing for stool culture, antibiotic treatment, or hospitalization. Now, the majority of cases of acute diarrhea are mild and caused by self-limited infections. More than 90% necessitate no diagnostic intervention and no treatment. And actually, the primary symptoms dictating the need for evaluation and diagnostic studies are those with severe infections, like high-grade fever, orthostatic dizziness or presyncope, bloody diarrhea, severe abdominal pain, or immunocompromised patients. In these patients, investigations should be done. We have to always check whether there is blood in the stools. We take stool samples for leukocytes, ova, and parasites. We may take stool culture and assess for Clostridium difficile toxin. We have always to check BUN, creatine, and electrolytes to make sure that the patient is not dehydrated and does not have electrolyte abnormalities. If the patient has bloody diarrhea and without a clear etiology, then sometimes a flexible sigmoidoscopy may be done to look at the mucosa and check whether the patient has any inflammation. The general advice is that patients need to keep their intestine at rest and be provided with fluids, hydration, and electrolyte replacement. Patients should ask to avoid milk, since lactase levels are very low when there is an infection. The patient will lose whatever small concentration of lactase is present. And this is especially true in the adult population. In the pediatric population, if the patient depends only on milk, it may not be possible to stop it, but children have enough lactase in general, so there is no harm. What is important is to give fluids. Easily digestible foods are most acceptable to the patient with acute diarrhea. So the major aim is replacement of fluid and electrolytes, administration of oral rehydration solution called ORS, either treatment of choice for mild to moderate diarrhea in both adults and children. The discovery of ORS is one of the most important developments in the last century, as it has saved millions of children and people from death. It is used in moderate diarrhea, especially in patients who can drink water and are not vomiting. This approach relies on one important mechanism, which is that sodium is absorbed in the intestine through sodium hydrogen transporters and through sodium glucose transporters. In most types of diarrhea, the sodium glucose transporter remains intact. All ORS contain glucose and sodium as the most important constituents. By using this transporter, sodium glucose, sodium is absorbed and water will follow sodium. Another option is to use starch, since starch is easily digested at the brush border membranes and then glucose will be absorbed with sodium. This explains the traditional recipe of offering rice water to people with diarrhea, since rice water contains a lot of starch. By boiling rice and adding some sodium chloride, one creates a good solution to drink that will lead to sodium and water absorption. We have to keep in mind that ORS do not decrease the amount of fluid that is secreted or the amounts of stools. This must be explained to patients, because if a patient has diarrhea and is given ORS, actually this might increase the volume or frequency of the stools. The patient should be educated that the purpose of ORS is rehydration and not stopping diarrhea. Now, for antibiotics use, only less than 10% of patients with acute diarrhea benefit from treatment with antimicrobial drugs. The most effective is quinolone, which can be taken as a single dose, according to some studies, or over 3 to 5 days. Now, for the antimotility drugs, sometimes antimotility drugs like opiates are used. These compounds increase transit time and decrease fluid secretion, and they also increase rectal sphincter tone. For example, loperamide is the best of these because it does not cross the blood-brain barrier. However, it is contraindicated in acute severe colitis. Generally, it is better to avoid the use of opiates in acute severe diarrhea, since in theory the body needs to get rid of the toxins and whatever is in the intestine. Now we move to chronic diarrhea, and the major cause of chronic diarrhea are first malabsorption, and examples of these are celiac disease, lymphoma, Weber's disease, pancreatic insufficiency, bile acid malabsorption. The second cause is inflammatory bowel disease, like ulcerative colitis, Crohn's disease. Third are medications. As I've already mentioned before, many medications have some side effects of diarrhea. Then we have the functional diarrhea, and this is in case in patients with irritable bowel syndrome. Sometimes endocrine diseases may cause diarrhea, like hyperthyroidism. Fecal infection may be a cause of chronic diarrhea, as I've already mentioned, in acute cause of diarrhea. And finally, neuroendocrine tumors like carcinoid, gastrinoma, lipoma can cause chronic diarrhea. Many times in chronic diarrhea, the physician needs to know the stool weight to make sure this is diarrhea and not just an increase in stool frequency or change in stool consistency. The history should address several questions. First, is the diarrhea nocturnal? And this to differentiate organic versus functional diarrhea. Usually patients with functional diarrhea do not wake up at night to go to the toilet. You should ask about diet history, ask about changes in patient's diet, for example using non-absorbable sugars like sorbitol. Ask about weight loss, So if a patient does not have any weight loss, this would argue against malabsorption, since patients who have diarrhea with malabsorption usually lose weight. Medication history is very important, especially the use of antibiotics, because of the risk of developing antibiotic-associated diarrhea, which is secondary to Clostridium difficile. We have to ask about the presence of blood or mucus in stools, so this will inform us about inflammation. We have to ask if there is alternating constipation and diarrhea, and this goes more with irritable bowel syndrome. We have to ask about previous medical and surgical history, and we have to ask about any associated symptoms like flushing, peptic ulcer. All these should be investigated. For example, flushing, raising the possibility of having carcinoid syndrome due to serotonin secretion. The presence of peptic ulcer disease, recurrent, severe, and non-responding to treatment, and diarrhea would argue for gastrinomas. The patient in this entity gets severe ulcerations in multiple locations in the intestine, and it is sometimes what even happens in the jejunum. We have to look for some associated findings like pain, abdominal distension, fever, anemia, cachexia, skin conditions like erythema nodosum or pyoderma gangrenosum, which are found in inflammatory bowel disease, dermatitis herpetiformis, which can be associated with celiac disease, perianal abscess and fistula, which also can occur in Crohn's disease. We have to look for arthralgia and arthritis, which is also found in inflammatory bowel disease. And as I've already mentioned, we have to ask about wheezing and flushing present in carcinoid, and look for lymphadenopathy, which is associated with lymphoma. The laboratory tests which can be asked for in patients with chronic diarrhea include stool exam for ova and parasites, presence of leukocytes, and this is called right stain. Check for calprotectin and lactoferrin, which tell us about increase in inflammation. We may check for Sudan 3 stain, which detects fat in the stools if you are suspecting malabsorption. Blood studies are ordered to check if the patient is anemic or if he has low calcium or low proteins. So the usual blood studies are CBC, calcium, total serum protein, INR, electrolytes, BUN, and creatinine to check for renal and hydration status. Sometimes colonoscopy is needed to get a diagnosis. In some cases, it may be necessary to check for laxative screen, since some patients take laxatives and have what we call factitious and malingering disorders. Sometimes we ask for specific tests. For example, if you are suspecting celiac disease, one can check for anti-endometrial antibodies and anti-tissue transglutaminase antibodies. For celiac disease, jejunal or duodenal biopsy should be taken, and a positive biopsy for celiac disease will typically show blunting of villi. Some patients may present with chronic diarrhea, and all the tests fail to reveal any cause. In such cases, we have to think about factitious diarrhea, and these patients are malingerers. They don't have diarrhea, but they want to consult a physician. They have some psychological problems. So here we have to check for stool osmolality. So if stool osmolality is less than 250 milliosmolar per kilogram, then the patient may be diluting the stools either with water or urine. To check if urine is added, we look for stool urea, since normally there is no urea in stools. Also, we have to check for osmotic gap. So if the fecal osmotic gap is more than 40, then the patient is taking some laxatives, some osmotic substances that are causing the diarrhea. Usually these patients are discovered after they are admitted to the hospital. Most of them stop having diarrhea in the hospital. They are just hydrated and prohibited from getting anything from outside or any medication. When rare causes are suspected, like neuroendocrine cause of diarrhea, for example, lymphoma, then measurement of VIP levels can be done. These are rare, but they need to be kept in mind. Carcinoid syndrome also, in these cases, need to be ruled out, so the patient gets an ultrasound of the liver. Usually, all patients who have carcinoid syndrome have metastasis to the liver. And to make sure that there is extra serotonin secretion, one can measure 5-hydroxyindole acetic acid in the urine, which is a metabolite of hydroxytryptamine. If it is higher than the diagnosis of carcinoid syndrome, becomes highly probable. If Zollinger-Ellison syndrome is suspected, gastrin level should be measured. Sometimes physicians take colonic biopsies to rule out an entity called microscopic colitis. So the colonoscopy may look normal, but on biopsy there is some inflammation. It's called microscopic colitis. Some patients may have bile salt diarrhea. Patients have defect in absorption of bile from the terminal ileum. So bile goes into the colon and induces diarrhea. Some patients would have bacterial overgrowth, such as in scleroderma. Despite all of these tests and tricks, there are around 10 to 15% of patients with chronic diarrhea who remain undiagnosed. So we don't have a clear idea why they have